Not too bad, I think. I don't think it's a scenario that I feel comfortable in at the moment. I don't know. I found myself reassuring myself as I went. The fact that I was able to ring and speak to the palliative team with a bit of the, not the prompt, but the information from the wife telling me that he'd under a team there, he'd done this. She couldn't give me the details, and I reflected positively in my troubleshooting to be able to go, well, I don't really feel comfortable taking your word verbatim for everything. Let's phone a friend. And the fact I was able to contact them and speak to them, it gave me some reassurance that the SIM went on. But to kind of walk in and have someone, I respectfully acknowledge the cardiac failure, and I respectfully acknowledge that he was in a VT, conscious VT. There was a natural instinct to want to go do something. So that whole system of a SIM and going, what do you want to happen, still feels fine. So realistically, this scenario made me feel a little bit uncomfortable, but I think overall I managed that well. I failed to recognise a little bit until the end, recognising the end of life component of how the patient presented, but was inclusive in the wife. Though the communication I thought was good, but I think I could have made it more personal. Once we sort of recognised that point, I spoke to the palliative care team. It was like, "We'll come in here, darling, and be a part of this." And it required a little bit of prompting towards the end that I sort of failed to pick up on that. So that was one thing that I felt I could drastically improve on.
I don't think it was significant prompting, and the way that you managed that SIM was very positive. I suppose the thing that I have a personal view on is that we include the family in death because it helps transition them into the grief process. But then, so that probably was just remember that this is simulation of real life. What would you do in real life? And you go, oh, I'd get mum to, the wife to come down and sit down and have a chat.
I also think positively that I pulled the brakes on myself from using that conscious VT or that language that particularly the family wouldn't understand. I was able to sort of say that rhythm is not sustaining with life, and it will progress that way. So I think I was smart in my communication as well in doing that.
So by far and away, the best in terms of run and control and a sense of direction that I've seen in the last 2 days. So even though you said you felt uncomfortable, it didn't come across that way. And we actually made comment when we were reviewing it. I think he knows his PAL care management. He knows how to deal with this situation. And that showed in your care. So it actually, when you said I felt uncomfortable, you didn't look it. You looked comfortable with me.
I think it was just more on the ground of the intrinsic habit to, if it's broken, fix it.
Yeah.
As opposed to going, well, hang on, you've given me some key words. Cessation of amiodarone, didn't think it was going to happen this soon, cardiac failure, multiple heart attacks and everything else. It prompted me to think, okay, righto, let's ask the ugly question. Is there an end of life plan? Are there wishes? Are there whatever? And I was able to probe a little bit. So just confirming, you say non-invasive, I'm putting a line in that's invasive. Let's get the consent of the wife.
We spoke about that, absolutely. We spoke about that. Everything that I think you managed within that SIM was done with a high degree of respect and consultation with the wife, and you included the wife. So, I think you should feel happy with how you went in that SIM. All right, let's go through each element. Clinical knowledge, anatomy, pathology, pharmacology, evidence-based practice.
I'll mark myself as assisted in that one, and that's purely on the basis of when I walked in systematically, I stepped my way through, my eyes are open, they're spontaneous. It doesn't respond to my presence, but I did that. But then I very quickly, in the heat of the moment, instead of doing what I used to do in my SIMs, AVPU, and be happy with that in my primary, I very quickly went to watch my GCS and I did the maths wrong in the head. I know I did that wrong.
No, some of that was that Potsy wasn't talking and he was meant to be talking. So I came in and just said, he's giving you confused responses.
So with that one, in reflection, I've given myself an assisted on that one.
We gave you independent.
the policy knowledge. Respectfully acknowledging that I need to incorporate the palliative care team in if I'm going to give analgesia and things like that. The actual wording within the policy on what my, I think my role in that end of life thing, you know, I felt a bit hazy on that. So I've only given myself an assistant in that one.
So what you did, in terms of your management, is in line with what the policy and the guidelines state. The only thing that we could have said, and then we spoke about this as being, you know, just the sprinkles on top of the cupcake, is a consideration about he wants to be comfortable. Is he comfortable now? Is there a role to provide some analgesia?
And where with the way he's going to progress with his VT, and you know he might be a little bit anxious in regards to when he starts to go unconscious and his respiratory rate. What can the palliative team offer with his drugs he's got there, such as the Ordine, and or what with the QS advice line you and the palliative care team come up with?
And I think that's the thing. Like you're aware that you needed a consult for it. You certainly can't give analgesia independently within that setting because there's clear guidelines about the management of a palliative care patient, requiring specific, tailored, patient-centric approach to their analgesia. So that's just a small thing. If the consideration was, and that's probably the next thing that you need to do again. If I'm here for another 15, 20 minutes, what can I do? But
I'm not sure, in reflecting it when I rang the PAL team and Dr. Bob was from emergency just filling the hole up there, I'm not 100% certain in my lack of experience in that field that Dr. Bob would have given me a definitive answer in that one.
And you know what, really, you consulted the appropriate palliative care team. You spoke to the doctor that was working in the palliative care team. It's similar to if you call the cardiologist and you ask if you're speaking to an interventional cardiologist and they say yes you are, then you still give the spiel.
Yeah.
But for mine, like you made a phone call, you didn't manage independently, and you respected you asked specifically what was in the care plan, the ARP. All right, safety manual.
I went independent.
Fine, history taking.
I marked myself independent on that one because I think I really probed the wife on the background. You mentioned cessation of meds, you mentioned cardiac cardiac failure. Can you tell me more about that? It might have been closer to the sort of 6 or 7 minute mark, but I probed it.
So the direct instructions I gave to Nat, and I said it a couple of times, don't give him everything. She gave you a bit, but don't give you everything, but don't be obstructive. So that if he asks you further questions, which you should, then you elaborate a little bit further. But it wasn't here's all the information on a platter. You'd have to go searching for it, which is realistic to someone who is overwhelmed by a situation. They're not going to give you a pitch perfect kind of handover of what the situation is. I thought you were respectful in the way that you took the history and you reviewed what the management processes were.
Mm-hmm. Physical examination definitely needed to be done as a part of that secondary survey.
Yep.
It was late in the case, so I've marked that more towards the assisted range. I think the pertinent, important points were done as we went, but I think the thorough me auscultating a chest to provide some positional support, or the head to toe to identify the edemesis leg to knees, wasn't done until late in the case.
When did you get your BGL done?
I couldn't even tell you. I know it was done, I know it was given to me, it was 5.5. I think it was just 5. But
you actually complete your first vital signs fairly early in the picture. The secondary and going back, like whether or not they've got fluids, given the state of the patient, like congested lungs, is it going to change your management? Potentially, if you need to ventilate the patient to give them a little bit of ventilatory support, but like, is that something that he wants? Does he want to be artificially ventilated? So like I think your exam was good. You identified that there were markers that were consistent with congestive cardiac end-stage congestive cardiac failure. Systematic approach.
I just went assisted on that one. I thought I was short and concise. I think I did my primary survey nice and quick. I obtained a history and a sample of the wife fairly promptly.
We agreed, but we probably bumped you up to independent in that. In that, there's probably a different sense of urgency within this sim. You don't have lots of competing priorities, but within this setting, you started and completed an assessment, and then the way that you managed, you went back, and it was visible that you were going back and you were re-examining GCS, airway, looking at breathing again, doing pulse checks again. You could see a pattern, you could see a system, you could see that you're returning to your system. It was the best that I've seen in the last 2 days, mate.
Vital signs investigations, I listed that as assisted. Development of working differential diagnosis, I listed that as an assisted. I think I recognised it and labelled it early. Yeah. I consulted with my team and mentioned what I was doing and what my plan was. Yeah. Management planning and implementation, yeah. I went sort of in between the assisted and the independent. I felt reasonably confident in my shoes that this is what I was going to do, this is what I wanted to do. Yeah. I consulted with the family about that, I consulted with my partner about that one.
So for those elements regarding your planning and your implementation, we didn't see any issue whatsoever. I think it was a well-managed, conservatively managed case that required conservative management because that was in the best medical practice and the best interests and wishes of the patient.
Procedural skill competency I didn't do. I didn't even tick that one because I kind of felt like there was no procedural skills in it.
Yeah, so the only thing that we spoke about is, do you consider the phone call to Dr. Bob procedural process? We didn't have an issue with it, whether or not it's not assessed or an independent, neither here nor there, mate.
Evaluation and reassessment, ability to modify management plans in response. I've gone as an assisted in that.
Rationale for that?
I continuously reassess my patients.
Yeah.
I recognised that I had a weak radial in the beginning and then I sort of didn't have a radial in the end.
Yeah.
But I don't think there was any sort of modified in the management plans in there. Like the only thing I wanted to try and do was to, with the full field crackles I had in the finishing, when I did the auscultation, I wanted to reposition him, just to sort of optimise if there's an ability to, with gravity or positionally shift some of that fluid down to assist with his breathing to make him more comfortable.
Yeah.
Unlabelled that. I didn't do it. I don't think there was the facilities in the room to do it. But
you ran the patient, you got information that he's got a slightly distended abdomen, you know that he's respiratory compromised, he's got a slightly elevated rest rate, you know he's got fluids on his lungs, and some of the information provides you that he didn't have great chest excursion in the bases. So I have no problems with you looking at positioning your patient a little bit higher. Yeah, they're ALAC, but like this is probably the circumstance where you have to go, they're already supine. We just have to assist what we can in this circumstance. Are you going to fix any of this? Definitely not. But your management. We gave you independent because you were very quick to say, let's put the pads on, and you were going down that pathway, and then there was a visible moment within that sim where it was like that, cool your jets, let's find out what we need to do. Let's talk to the wife. And I think that's your big management or your evaluation, your modification of your plan, was that you stopped your aggressive management, you looked over and you started consulting and talking to the wife, finding out further information and going, you know what, we're not going to shock this patient. It's not what they wanted. Like that's my observation and the evaluation. So we thought that was...
communication with the team I thought was good. I think communication with the patient was also good. I sort of tried to explain to the patient what I was doing and we offered some reassurance there.
Yep.
I've marked myself and assisted even with the question mark towards dependent on the consultation with the wife. So it was just I think the communication was good, but just that, as I said before, that personal interaction, that personal involvement and giving her an opportunity. Like I would have hated to have been in that sim in that life in the real world and have him die right there in front of me while Sal's on one side, I'm at the head, and the wife standing on the other side of the room. Like I think many of people, she has the right to say, no, I don't want to be there.
Yeah.
But I didn't even offer that.
Yeah, and you know what, like, that's a good reflection. And you know, I prompted just to kind of say, hey, we're at the end of the sim anyway, is there anything else you'd like to do? But for mine, I thought your communication with the wife and the partner and your crew, and it's probably the most that I've seen closed loop and checking in with your crew.
I agree.
Was at a very high standard, at the standard that we'd expect to see someone.
Leadership, again, I think it's just from that same thing, the team management. I think I tasked Sally nicely, but it was just the leadership, and it was just on that, again, it's that holistic inclusion. There's times that you want to involve the family, there's times that you might have a trigger or an ABD situation that a family member is a major trigger and a cause of this, and your leadership would be to remove them from the room. I think the leadership also is that inclusive process. So for me, in reflection of what I've felt leadership across the sims I've done, that one I marked myself in the assisted range, just simply again because I didn't sort of say, come over here, darling,
But we like, in the sim, you want to do that, but that's something that's not critical to the element of the sim. We gave you an independent in that area, mate. Calm control, did you feel calm control?
Yeah.
A little bit.
Other than the fact that, as I said, it was just a situation that, I wanted to intrinsically do something, but not at the same time. Medical documentation, not applicable.
No.
The clinical handover, I obviously made a consultation, so I've ticked that box there for the palliative care team. I've marked that as assisted. I think I introduced myself, I introduced my patient and confirmed without offering the bias to the telephone consultant in the end. I didn't say I've got this and this before they were even able to consult the file.
Yeah.
And I think I gave them the opportunity to give me an unbiased input into the care and the, I guess the wishes of the patient. I wasn't ringing up and going, I just want to confirm there's an ARP, and having a doctor going, well, you've run the palliative care team, of course there's an ARP.
Yeah, I suppose, listen, we did NA because it was, I don't think it's a handover. What you did was that you did a procedure, which was you did a consultation for care within there. In there, you probably needed to provide a little bit of handover, and that's the prompt. Like if you talk to a doctor about logistics, you can expect at some stage they're going to say, "Why are you calling, mate? Just tell me what's going on there," because they're going to be juggling the logistics of.
Normally,
I've got 20 patients to see. I've got 2 that are, at end stage and requiring end of life support in the next 6 hours, and I've got an ambo on the line asking me about logistics.
normally when I consult, I normally sort of look at what I do on the case sheet. I taught on the case sheet years ago. One pertinent sentence that describes a lot. It's Gav here, one of the critical care paramedics in Queensland Ambulance. I just want to consult about a palliative care patient that I'm at home with at the moment. So straight away he knows you're a paramedic and you're at home with a palliative care patient. And then off you go.
So that's a small thing, mate.
Mm-hmm.
But you know what? Your doctor's always going to ask a question. They're not going to die wondering. They're going to, why are you calling me, mate? What's going on there? So
I think I gave that
Yeah.
as it went on, but I just gave that opportunity for the, the critical thinking side of it, the risk benefit, troubleshooting the problem solving, the plans ahead. I think I marked myself assisted on that, but I think that's just based around that overall sense of, uncomfortable sitting on the fact that I've got a patient that's going to die in my hands in the next couple of minutes. The way the trend was going, I've now lost radial pulses. I'm sure the blood pressure would have been lesser again. It's going to happen soon. I think the palliative care team was going to get there in that 15 minutes to still be alive? No, I don't. No. But, I just think overall, I've just marked myself in that assisted situation because that was just an environment that I've had no exposure to. And it was, 100% fictional, and I had to try and think within that.
So we gave you independence across the board. We thought that was a very solidly managed sim. What you demonstrated in terms of risk benefit, fine. We spoke a little bit about if you are going to give fluids, just give a rationale. Like I know my patient's got end stage cardiac failure, but I also know that they're volume depleted and they're probably dehydrated. And I know that potentially I'm going to worsen the outcome if I give them fluids, but if they're dehydrated I can make them comfortable. Then that's the, wow, he's really thought about what he's doing and what the risk is, and he's weighing up the risk while he's doing the activity. Troubleshooting, problem solving, thinking ahead.